All right. Hello, and welcome to the Psychedelic Skeptic podcast, where nothing is a cure for everything. I'm your host, Ann Metz. I have an exciting guest with me today on the show. We have Dr. Scott Shannon. Dr. Shannon has been a student of consciousness since his honors thesis on the topic at the University of Arizona in the 1970s under the tutelage of Dr. Andrew Weil. Following medical school, Scott studied Jungian therapy and acupuncture, while working as a primary care physician in a rural area for 4 years. MDMA-assisted psychotherapy became a facet of his practice before his medical residency was scheduled. Let me start that over again. I got that one jumbled. I apologize. I'll give myself one mulligan. Hello, and welcome to the Psychedelic Skeptic podcast, where nothing is a cure for everything. I'm your host, Ann Metz. So I have an exciting guest with me today on the show. We have Dr. Scott Shannon. Dr. Shannon has been a student of consciousness since his honors thesis on the topic at the University of Arizona in the 1970s under the tutelage of Dr. Andrew Weil. Following medical school, Scott studied Jungian therapy and acupuncture while working as a primary care physician in a rural area for 4 years. MDMA-assisted psychotherapy became a facet of his practice before this medicine was scheduled in 1985. He then completed a psychiatry residence at Columbia program in New York. Scott studied cross-cultural psychiatry and completed a child and adolescent psychiatry fellowship at the University of New Mexico. Scott has published 4 books on holistic mental health, including the first integrative psychiatry textbook for this field in 2001. His pediatric mental health textbook was published in 2014. Scott is also a past president of the American Holistic Medical Association and a past president of the American Board of Integrative Holistic Medicine. In 2010, he founded Wholeness Center in Fort Collins. This innovative clinic provides cross-disciplinary evaluation and care for all mental health concerns. Scott serves as a principal investigator and therapist for the Phase 3 trial of MDMA-assisted psychotherapy for PTSD, sponsored by the Multidisciplinary Association for Psychedelic Studies, MAPS. He has also published numerous articles about his research on CBD and mental health. Currently, Scott works extensively with ketamine-assisted psychotherapy. He lectures all over the world to professional groups interested in taking a deeper look at mental health issues, safer tools, and a paradigm-shifting perspective about transformative care. In addition to his practice in his psychedelic training program, Scott is currently involved in the implementation process for Colorado's Prop 122. Prop 122 decriminalizes the possession and the use of psychedelic mushrooms and certain plant-based psychedelic substances for adults aged 21 and older. Prop 122 also requires the state to establish a regulated system for accessing psychedelic mushrooms. He also worked to create a nationwide board-certified psychedelic provider designation for clinicians interested in working in the psychedelic space. He is, in other words, the hardest working man in mental health. Scott, thank you so much for being here today.
Happy, Ann. You didn't need to blather on quite so long about me, but yeah, I'm very happy to be here.
Well, I'm just really excited to have a guest who has such a broad, expansive background and a really unique perspective on what mental health services and what mental health care really should look like. So thank you so much for being here.
I've been thinking about those things a lot, and I think of myself as an ingrained skeptic, so I think it's a good fit for what you do. Happy to be here.
Great. Excellent. Well, as I mentioned in the introduction, you've had a lifelong interest in consciousness. Can you tell me a little bit about how psychedelics entered into the scene for you?
Well, I went to the University of Arizona in the early 70s with an interest in consciousness, but a rather naive overall sort of life background. I was raised in a pretty sheltered family with a lot of kids, and we stayed active and outside and otherwise naive. But I got to the University of Arizona, and pretty quickly at my fraternity, I realized there was a lot more to life than I had encountered before. And one of those was just the whole realm of psychedelics. I happened to encounter a group of people who were very confirmed and dedicated psychonauts. They weren't there just to get loaded and to get drunk and wild, but they were really curious about consciousness and the inner space. And that combined with meeting Andrew Weil. And so I described this combination as the lecture in the lab.
Mm.
And so I think I got a pretty significant introduction to psychedelics while an undergrad, but it dovetailed nicely with my interest in psychedelics, or my interest in consciousness, and how these two help us to understand the other. So it was a pretty interesting start, and it has continued to this day.
Great. Well, I look forward to hearing more about how psychedelics as a therapeutic treatment emerged in your journey as well, too. But I'd like to maybe start with, the early days of your career in psychiatry. So you came into psychiatry at a moment where there was a similar sort of optimism for a radical new treatment, SSRIs, the selective serotonin reuptake inhibitors, with Prozac being FDA approved in 1988. I'm curious what parallels you see between what was happening when you first started out in the late 1980s and what we're seeing now for psychedelics.
Well, I think the mid 80s through the mid 90s, there was really this frenzy about SSRIs, Prozac in particular, but I think that it's extended to a lot of them. And there was this building optimism, excitement, almost a mania about this, that within 20 years between our selective targeted psychopharmacology and the Human Genome Project, there would be an end to mental illness by the year 2000. And I think everyone was just very excited. And I also, just entering the field at that point, was caught up in this as well. Although from the start, I had approached medicine and psychiatry with an integrative, holistic perspective. And coming through medical school, it was pretty debilitating. And I actually got pretty depressed in my last few years of medical school and contemplated leaving the profession, just because the practice of healing that I saw in hospitals was so different than what I had learned about, conceptualized, dreamed about as a holistic healthcare provider. It was pretty debilitating. But I think I came into psychiatry and the use of medications a little bit of a hippie skeptic, because it wasn't natural and it was an artificial manipulation of the human system and the limits of that. And so I'd always had this bit of ambivalence that I carried with me. And it was further exacerbated in 1988 when, as a psychiatry resident, one of the first patients that I worked with, a depressed guy from rural upstate New York, and I think around 40, had a couple young kids, a wife, but he'd become very depressed, very isolative, and just kind of flat and withdrawn. And I prescribed Prozac for him. And at that time, there was not a 10 milligram dose. Everyone started on 20 milligrams. So I started him on 20 milligrams, and I got a call and then scheduled to see him back in a few weeks. I don't know, 3 or 4. I got a call about 10 days later that he had killed himself and jumped off a bridge into an icy upstate. And his wife had told me that he had become progressively more agitated since he started taking the Prozac, with a lot of restlessness. And this culminated in this event. And we've since come to learn that some amount of people develop akathisia with Prozac because it's such a stimulating SSRI. And we now know that we start most people at 10 milligrams and work them up to 20. But she ended up going on and suing Lilly, and was one of the initial people in the case against Lilly and the suicidality triggered by Prozac. And the suit was settled. She never felt like I had done anything wrong, but she from the start blamed the medicine pretty squarely. And that really hit me right in the gut, because it's one of my first patients, suicide, likely from something that I did. And I never really squared myself to that. And I think for the next 30, 40 years, I don't know how many, 35 years, I'd always had this ambivalence about prescribing psychiatric meds. I prescribed them cautiously. I prescribed them in a limited way. I tended to take people off more medications than I put them on. And we also very actively look for other options. And as psychedelics came in and ketamine came in the last 8 years, it has really opened that up. And I actually retired from prescribing psychiatric meds this past summer after 40 years, and am now just doing psychedelics and medicine work and sitting with people. So it's been a full circle for me. And what I've seen is that initially there was this mania with Prozac, and that sort of died down and I think leveled off around 2000 when it became clear that we were not going to achieve anything of what we had thought, and that the Human Genome Project basically really failed to change psychiatric practice at all. And what we were seeing initially and sort of building over time with these psychiatric meds helped some people, they hurt some people, and a lot of people, they just dulled their misery, and we could manage it. But nobody was ever cured by these things. And what we saw over time is people became adjusted to these things, required monthly med checks, and that we were just fighting a losing battle with the body's homeostatic practice, homeostatic principle, where it self-corrects. And basically, anytime you put a perturbation into a human body, the body, in an effort to maintain health and balance, will try to correct that. So if you add acid to the blood will buffer it and become more basic. And if you make an intervention with an SSRI, the body adapts by changing receptor sensitivity and downwardly adjusting sensitivity to compensate. Well, the end result of that is that people feel muddy, muted, no sexual sensation, reduced sexual pleasure, there's one study that I really enjoyed. I don't know if I enjoyed it, but I found it very valuable, that couples who are on an SSRI feel less passion and affection for the other compared to their prior. And so they mute a lot of feelings. And over time, a lot of people are chronically stuck on these without benefit. And I think, the final straw for me in the chemical imbalance theory was the publication of Robert Whitaker's book, Anatomy of an Epidemic, I think in 2013, 10 years ago. But basically in that book, he outlines how 4 different diseases, ADHD, depression, anxiety, schizophrenia, are impacted by the chronic use of psychiatric medication. And what he outlines, he was an investigative reporter, a very thoughtful guy. I've met him a few times, worked with the Boston Globe. And but in this, he really documents that the more chronically you're on psychiatric medication, the less likely you are to find improvement, and the more likely you are to have chronic symptoms and to need ongoing medication management. And that book was sort of the final nail in the coffin for me. I think there was another study that came out around that time that showed that SSRIs were as effective as SSREs. So they had selective serotonin reuptake inhibitors and selective serotonin reuptake enhancers. And they both had approximately the same effect. And there's a great book, The Emperor's New Drugs, by Irving Kirsch of Harvard. He's the director of the Placebo Center at Harvard, Center for Placebo Studies. And he basically documents that most of our pharmacological studies with depression show benefit because they're active agents, like an active placebo. So people get side effects, they think they're going to get better, and expectation, the placebo response, gets them better. And, I think over time, what we've seen with the chemical imbalance theory is there's probably evidence there that these are active placebos, and probably little more than that, but with a significant downside of chronicity, habituation, dependence, and iatrogenic effects. So I could talk for years on this topic, but I'm going to shut up.
Well, I am really glad that you brought all of these things up. And I think that, one of the challenges always in being an educator, I think, is really helping students and then consequently helping their clients sort of recognize that what we've been told about the chemical imbalance theory is about as close to being disproven by science as a theory can be proven. So and so I'm we also think about that as well, too, that our model for depression as a chemical imbalance was to some extent reverse engineered from medication that seemed to be efficacious. And so I'm wondering about psychedelics, if they're efficacious with psychiatric conditions. What does that say about psychiatric conditions? What's the model that comes to us through psychedelics?
Well, there's a lot of great questions and depth buried in there, Anne. I'm happy to dig into some of that with you. So a couple things. One is that with psychedelics, what we see is that they appear to benefit transdiagnostically. And what we know now with psychiatric diagnostic system is it's really a superficial phenomenology, is that we're much more gardeners than botanists in the field of mental health. And that we can pick out things that kind of look alike from the surface, but we have no idea their underlying structure. And psychiatry has gone in the wrong direction when we look at specificity of illness and the sort of coefficient of reliability that we get into with our diagnosis. So what we have is these broad wastebasket categories that just look and blend imperceptibly into another thing. One great study out of Denmark, and they have a captive audience pretty much in Denmark, 6 million people, I think. And what they found is they looked at people with psychiatric illnesses, and then they looked at their children and grandchildren to see if they bred pure, just from a diagnostic clinical monitoring point. And what they found is that really any psychiatric illness could become any other psychiatric illness. And there was really little genetic pedigree to this that they could tell. And that there's a generalized risk. If you have a psychiatric disorder, you're much more likely to have children with a psychiatric disorder, but they can all look very different. And I think what that tells us, we found this out with the Human Genome Project, is that genetics are not that helpful in this arena. It's really environmental, it's trauma, it's a lot of social determinants of health, et cetera. But there are some risk factors. But beyond that, it's very difficult. What we see with psychedelics is that they appear to help a broad range of things. Mm-hmm. Initially we thought with ketamine, this is really treatment-resistant depression. And pharmacologically, that seems to be what it does most easily. But we're now building evidence that it helps with trauma, it helps with anxiety, it helps with a range of things. And it looks to be a non-specific augmenter of psychotherapy. And that's really how we see it. So I think the diagnostic system in psychiatry is very, very broken. That's why I labeled one of my books, Please Don't Label My Child. There's much to be lost and little to be gained with psychiatric diagnosis. I think in general, it points us towards different treatments. But what we see with medications is that, if someone fails on one or two different antidepressants, they try them on a mood stabilizer, they try them on a stimulant, they try them on anti-anxiety agents, they just start freewheeling. And you see this in psychiatry patients. They're on 3 to 5 different medicines of a range of different categories, and it's mostly out of desperation. And I've been there, and I know what that feels like. But it's not ultimately, I think, a rewarding practice.
So presumably the work that you're doing now, I would imagine, doesn't feel like it's motivated in a sense of desperation.
No, I think it's really motivated by hope, because what we see is transformational change. And that's one of the things that attracts me most to psychedelics, is that we're not managing people with daily doses of medicine to mute their misery. We're actually giving them an opportunity for core healing, transformative change. And, I think the beautiful thing about a psychedelic treatment plan is it may involve 2 or 3 exposures of psychedelics. Ketamine seems to be a little different, but with psilocybin and the work we're doing in our clinic now, and the research we've done with MDMA, LSD, and soon 5-methoxy-DMT, it really shows us that these things can be transformative and that people are not dependent on medication with an inherent increased risk of side effects and dependence.
It almost sounds like we're describing a new paradigm in mental health that comes to us through psychedelics. Could you maybe talk a little bit more about paradigms in mental health and what we can kind of learn about those and understand about what the future holds?
Yeah, and if I was to characterize the psychedelic paradigm, it's that we've moved from a suppressive model of the psyche to an evocative model of the psyche. And really, we're honoring the ability of the psyche to heal itself, as opposed to a model that is really focused on pathology. When I wrote one of my textbooks, I did a deep, curious search for psychiatric models of health, as outlined in a psychiatric textbook. I could not find one. Mm. There is no psychiatric model of mental health. All there is let's find some pathology and throw some treatments at it. There's really no core underlying philosophy. And as we move from this suppressive model that is modern conventional psychiatry to psychedelic medicine, we move to an evocative model that honors the healing power of the psyche and really honors people's ability to get well if we remove barriers or enhance supports. And I think of psychedelic medicine as a catalyst that removes some of our barriers. And the barriers that we get from humans are our emotional, somatic trauma that comes to us in so many different ways, so many different levels. And how do we move beyond that? And then we have our own self-imposed trauma of our self-referential loops of negative self-image or pessimistic talk or, our personal negative narratives, whatever they are that limit us. Psychedelics help us to move beyond that and see ourselves in a cleaner, more pure way as we might have, if we approached life with a clean slate. And then, that wears away and we go back to our usual state. But we now have a reference point, a model, and that can help us to swim through some of this distress and get to a point where we're more buoyant and sort of find our natural mental health. So that's this current psychedelic paradigm. But we go back, there's this long history of moving through psychedelic paradigms. We can start out with the heroic medicine paradigm of Benjamin Rush. And, it's an era of heroic medicine because if you survived the treatment, you were a hero. This is bloodletting, and it's a lot of other very invasive and detrimental approaches. It was really, frequent in this country around 1800. And then we move into a bright spot, which is moral treatment in the Quakers. And this was really an idealized treatment where they treated people humanely and respectfully and tried to have them in nature and have good diets. It's sort of the original holistic approach that people could heal themselves. But that faded away with the Civil War, and we moved into an era of asylums, large institutions, and we had psychiatrists, as they called them, alienists, and they were just basically managing people in these large institutions. And it was an attempt to do something, but people really didn't know so much what they were doing. And then around 1900, we had this whole drive around eugenics and purity and mental health. And this sort of, in its most perverse way, became, Nazi Germany and clarifying the Aryan race. But there was really this understanding that genetics were important and that we should get rid of the defectives, these people that had significant illness because they were polluting the gene pool. And I mean, it's horrific for us to think about it now, but this was really the rage among intellectuals in 1910 and 1920. And then we moved into the shocks and surgery phase where we had psychosurgery like lobotomies. We had insulin shock therapy and electroconvulsive shock therapy. And these things, when the 30s, 40s, 50s were all the rage in psychiatry. And as recently as 1950, the inventor of the lobotomy won the Nobel Prize in medicine. So it's not been that long ago that we were really cutting up people's brains to mute their misery and make them easier to manage. And then finally, we move into the chemical imbalance theory. And I should say overlapping all this was Freud and psychoanalysis, psychotherapy, which became this sort of separate thread to all the somatic approaches that psychiatry took. And, as it stands now, we have these two threads, talk therapy and medication therapy, that are these two divergent arms of mental health. And psychedelics brings them together for the first time in really a unified worldview of what we're trying to do to help people heal. So interesting paradigms, but 30 years from now, 40 years from now, psychedelics will be passé, and we're going to move on to something else because we're going to realize the shortcomings of psychedelics. We're going to realize how limited our view that we're taking on about the psyche is. I mean, it's just the nature of human learning and the complexity of the human brain. And the fact that paradigms they're partially based in science, but they're also a social phenomenon. So, and social mores, social ethics, social energy shifts over time.
Wow, that was an incredible overview of the history of mental health treatment and what a horrifying history it is in a lot of ways. The exception of obviously Quaker treatment there. I'm sure that there are a lot of therapists that are listening to this podcast, and a concept probably that they've encountered as they've sought training in psychedelics is the idea of the inner healing intelligence. And what you just said was really provocative for me about seeing the mental health paradigm as being reflective somehow of our concept, the context that we're in and the moment that we're living in. And I'm curious if you have any thoughts about psychedelics' reliance on the inner healing intelligence and how that somehow relates to the moment that we're living in.
Well, I think, as you well know, we're in a moment that has a spiritual vacuum. Materialism is our religion per se. We're facing an era of increased strain, stress, anxiety, social pressures, political division, animosity, and it's just social media. It's just a tough time to be alive, and there's a lot of tension in the air and a lot of anger under the surface. And I think people are hungry for some respite from that. And I think psychedelics offer an entree to a more spiritual perspective of life. They offer some relief from this increasingly self-imposed traumatic world that we're living in. And so I think it's a moment where psychedelics are calling to us, I think mostly out of spiritual hunger. But I think there is also some desperation and release that people are looking for.
Interesting. You would think in a moment where we're feeling, I don't know, this is a thought that's completely unformed that I'm just freestyling right now. Then in a moment where we're really reaching out for community and we're really lacking that sense of connection, that the healing wisdom is the wisdom that's inside each one of us rather than a wisdom somehow that's collective or shared.
Well, good that you mentioned that, because I think one of the things that psychedelics do is they help us to see that we exist in community and that really love is the currency of human interaction that we crave so much. And psychedelics open us up and help us to realize that we need community, we need connection, we need to reach out, we need to step out of our isolation. And so I think that psychedelics perfectly interdigitate with that. And that one of the messages as we go into our session in sort of quiet desperation, one of the messages coming out is love is really what there is, and relationship is how I share that and receive that. And so it's a communal message that I see coming out of psychedelic sessions so often. It's relational. Us to see the relational basis of our survival.
Thank you. That was really, really clarifying. Returning, I guess, to the topic of this podcast, which is the challenge of scaling research trials to a mass market mental health treatment. One of the concerns I have about the future of psychedelic medicine is that it won't work necessarily for everyone. I'm curious to what extent you've seen this in your ketamine practice or in the clinical trials that you've been involved with.
I've seen it in everything that I do, in every sort of treatment that I've undertaken, whether it's nutritional treatment or psychiatric medication or ketamine or psilocybin or MDMA, is that some people respond and some don't. And the takeaway message to that is that we're not as smart as we think we are, that people are complex. We don't really understand them all that well. And the more treatment options that you have and the more paradigms that you're comfortable stepping around in, the better off you are.
Yeah, I think that there's another way in which we sometimes talk about mental health conditions as a way that what we're trying to do is to eradicate them and to make them not be there. And I don't know that that's a realistic goal for really anything. And, if that's what the bar for success is, then it's probably always going to fail.
Yeah, I think expectations have been set way too high with psychedelics. I think people are coming at them. And, I think in some ways, 2 to 3 years ago was the peak of the sort of psychedelic mania, at least as I saw it in business. People were just throwing billions and billions of dollars at psychedelics. I think that has quelled and been quenched to some degree. But I think a lot of patients read Michael Pollan's book. They hear about some friend. They see something in the news. And they come at this, they're coming out with high expectations, but also a lot of desperation because psychiatric medications are just have very limited usefulness.
Yeah, I think that is really the sad reality of it, that, certainly there have been people who have benefited from it, but in terms of being a consistent, reliable treatment for anything other than symptom reduction, I don't know that they could really argue that.
In psychiatric medicine are often best in crisis intervention because you create some short-term support while you bring in external supports and develop coping skills, et cetera, and then try to move away from it. And that's really the model that I found was most useful. I think putting people on them with the understanding that they were going to get better just because of this, the silver bullet fallacy, sort of fell away pretty quickly for me.
Do you think that the same thing will happen with psychedelics, that people will just take psychedelics and think that they're going to get better?
Absolutely. I tell people that psychedelics are not a mental health care system. Psychedelics are a powerful, useful tool when combined with a comprehensive system of support and treatment. And so what I tell people is that psychedelic medicine really has no really effective educational prevention angle. You can say, well, early intervention or maybe ongoing psychedelics may keep people more mentally healthy. Well, maybe. But does that mean that we shouldn't educate them about things that we know are healthy and intervene around relational issues or family stress or behavior problems, et cetera? It's funny, as a child adolescent psychiatrist, I take a very developmental framework to all this. And, what I see is that psychedelic medicine is useful if someone has come off the rails at even 15, maybe 20, maybe 30, or, end of life at 70 and 80 and 90. But do I think we're going to be routinely using psychedelics on 5-year-olds? No, that's crazy. 10-year-olds? No, I don't think so. Even 15-year-old is a bit of a gamble. But what we need a comprehensive system that has prevention, support, education, talks about diet, stress reduction, mind-body techniques, and that integrative medicine really provides the broad platform that's needed. And psychedelic tools provide the powerful interventions when we're looking at significant pathology or stuck process, that we can use psychedelic medicine to intervene. And then psychedelic medicine can be a tool for helping people build awareness, but probably meditation is a better technique to teach people than teaching them how to take psychedelics.
Interesting. This relates to a question I was hoping I could ask you. You've obviously been a leading voice in favor of ketamine treatment. And I know that you have a speech, or had a recent speech by the time this airs, at the American Association for Ketamine Physicians, in which you make the point that ketamine is not the answer. I wonder if you could maybe talk a little bit about that perspective. And, firstly, what question is it that we're asking, and what might truly be the answer?
Well, that's sort of the takeaway, is it really depends on the question we're asking. And, if it's like, how can I most quickly get psychedelic tools in my clinical practice, then ketamine is the answer to that, because it's legal, it's pretty safe, it's pretty easy to work with, all those things. It's pretty gentle. I think that if we're looking for simply the quickest transitional tool to psychedelic medicine paradigm, ketamine is the answer. But I think I titled it that way because I am a bit of a skeptic at heart, and that what I don't want us to do is to get so focused on ketamine that we lose sight of what we're trying to do. And what we're trying to do is not treat people effectively with ketamine. What we're looking to do is get people to a place of mental health, balance, and wellness and wholeness that they don't need treatment. And that's really our goal. And I think we accomplish that goal best, as mentioned, with a broad range of supports and interventions, and using ketamine to help us work with the psyche, to help people learn and grow and develop. And so the answer isn't ketamine. The answer is the human psyche and our capacity to grow and heal. And that's where we need to stay focused. And the question is, what is our end goal? It's not ketamine. Ketamine is not the answer. Our answer is the human psyche and finding transformative paths that get us there. And, 30 and 40 years from now, we're probably not going to be using ketamine. And will we be doing neurofeedback on selected networks and hubs within the brain that are targeting specific symptomatology? Yeah, maybe. And maybe we'll, the thing about new paradigms is we don't see them as they approach. So I have no idea what the next paradigm will be, but I'm pretty sure, 50 years from now, we're not going to be prescribing ketamine and psilocybin to people.
Amazing to think that far ahead.
Well, you think about a human life. If I'm treating a 10-year-old, they're going to be around in 50 years. I'm not going to be, but they will be.
Yeah. Yeah. I wonder if I'll be practicing in 50 years. Probably. Let's hope not. Assistant professor salary might make that so, but we'll see. I am curious if you can talk about this, and if you can't, I also understand. What is happening with MAPS on the FDA approval process for MDMA?
Interesting side note. We finished our last patient visit in October. We closed out our site after 7 years of research with MAPS on our MDMA trial. And the final phase 2 study was published in September in Nature Medicine. So the data is all being collected to submit the IND to the FDA in the next few weeks. What I heard was mid-December, although knowing MAPS, it'll get pushed back. But they want to do this quickly. Then the FDA has, I think, a month to come back with questions or clarifications. And once the application is finalized, the FDA has 6 months to respond. And so we're pegging somewhere around August, where we might ostensibly receive FDA approval. Then it's probably going to be a 6-month process for MAPS to roll out, understanding what all the REMS are, the risk evaluation mitigation strategies. These are the guidelines put in place by the FDA, mandatory guidelines. And those can be things like you'll need an overnight stay at the facility. Likely not. I think we may have to dodge that bullet. Whether you need 2 licensed professionals in the room, maybe not. Dosing, frequency of visits, those kind of things. There may be a lot of structure to it. I'm pretty sure they're going to say only with clearly diagnosed moderate to severe PTSD. And, I think we're going to have little off-label use for a while. Off-label use means we could treat someone for other problems, like marital stress, I'm a big advocate for that because I think it's just a beautiful medicine for dealing with marital problems. But
yes, it looks like it would be great for couples work, but again, would not, unless someone has PTSD in the couple, I would assume that it wouldn't be an option for that sort of treatment for a while.
Actually, the trial with PTSD, a couples trial underway where one of the dyad has PTSD and the other does not, and they're treating both with MDMA. So interesting relational work. But, that's the type of thinking we need to get more systemic in our treatment and our thinking.
Very cool. And a related question, people often ask me when psilocybin is going to be slated for FDA approval. Do you have kind of a prognostication on other psychedelic medicines that, are in clinical trials right now?
Well, with Compass and Usona, I think Compass is into their phase 3 trial. Usona is just starting their phase 3 trial. Compass is a for-profit organization. Usona is a nonprofit based in Madison, Wisconsin. And, we're likely years away, 2 to 3 years with Compass, maybe further with Usona. It just takes so much longer than you think. But if Compass were to finish their phase 3 trial next year, submit, they might be lucky by the end of 2025, but it's probably going to be 2026 before we see psilocybin. But the good news is in Colorado, we've got personal use criteria under Prop 122. And using a harm reduction model, we're able to sit for people in our clinic now, psilocybin. So it's, we're making progress. And I think we're really beginning to understand it more clinically. And frankly, it's a lot easier to work with it in this non-medicalized model than it would be with FDA and REMS, but I don't think MDMA has enough risks that it's likely never going to be a personal use decrim model. It'll probably always be medicalized, but psilocybin and some of the other agents, mescaline, ibogaine, who knows?
So in that situation, I would assume that your patients would bring their own BYOM and you all would sit with them. And is that how your harm reduction model works?
Well, basically, they have a harm reduction session, and there's a nonprofit that contributes free to the patients their product they want if they've made that decision they want to do it, so that we can guarantee we have some sort of surveillance on the product that they're getting. It's basically a harm reduction approach. But yeah, they've made the decision. It's not being recommended or prescribed.
Okay. All right. Great. That's interesting. I've been wondering where things sort of stood with the GCRIM movement in Colorado. So that's helpful information.
Licensing and licensed centers, healing centers, and licensing facilitators is in process. It's coming within a couple years, and it's underway in Oregon now. So things are happening.
Yes, lots of things are happening. And I think one of the things I really want to make sure that we get a chance to talk about is the board certified psychedelic provider designation that you've been involved with setting up. Obviously, you have a really excellent training program called PRATI that does ketamine assisted therapy trainings. I'm kind of wondering what you're anticipating in the future and where things stand with that provider designation.
Well, BPMT, the Board of Psychedelic Medicine and Therapies, was started a couple of years ago. I stepped away over a year ago after being involved for quite a few years, founding CEO. And it's making progress. And I think it's really what we saw in integrative medicine, that this was really important for bringing credibility to the field and some definition and specificity. We also have APA, the Association of Psychedelic Practitioners, American Association of Psychedelic Practitioners. And that's also working hand in hand with BPMT. So I think these things are important for the maturation of the field. We have really an infantile field where training is willy-nilly. There's no criteria. There's no curriculums that are, predictable, and prices all over the place. But almost none of these programs have clinical experience or what we would call an internship or a residency built in. And that's just the very nature of an infantile field. But I think clinical experience is the thing we are most lacking in the field.
That's really helpful. I mean, I think at last count, or I saw an infographic about psychedelic education, and I think there's something like 150 providers of psychedelic education for training right now, which as a clinician who's interested in doing continuing education in this area, it can be really hard to pick what sort of program to take. So I think that's helpful for folks who are thinking about it, is to make sure that the facilitators have some experience doing this work, I would imagine with MAPS or with another clinical trial.
Yeah, I mean, that's with MDMA, that's the only way it has happened. So as a result of that, and MAPS requires a clinical episode with MDMA to be fully certified as a MAP therapist. And because of that, there's only a few hundred MAP certified therapists in the country. I think we've trained 15 at our site. It's quite a few, at least a dozen. And, but we're one of the largest sites. I'm sure others have many fewer. And, so that's a big drawback. That is a pinch point in this whole process.
Yeah, I sometimes wonder if they're going to end up getting rid of that requirement just because of the bottleneck that's going to create with, being able to sort of get these treatments out to people.
To MAP's credit, they have been very focused on the quality and very focused on instilling a lot of sound principles and quality assurance. So, to their credit, maybe they won't, but that's going to limit their commercial viability, I think.
Interesting. Well, for our last question here, Scott, I would just ask that you imagine 30 minutes from now, what would you wish you had said during our conversation, maybe that hasn't come up yet?
Well, I think I would talk about microdosing.
Great. I would love to end on that note.
It has become so common that I talk to people, even people that are in a conventional psychedelic frame. What are you doing? Well, I'm microdosing psilocybin as well as taking my 3 psychiatric medications and going to therapy and doing this and that. And I just got some pretty strong opinions about it. Number one, basically with microdosing, we're looking at daily dosing or intermittent dosing on a regular basis every 3 days, 4 days, the Stamets stack. There's a lot of other things that are going on, but they're providing a regular routine exposure to medicine that starts to look a lot more like the Prozac model of treatment, and that people are being managed with regular dosing and not looking at transformative options. But I also know that people have been dramatically helped by microdosing and have a number of even close friends that swear by it. So it's, where do we go with this? There's now publication out showing that an increased risk of valvular heart disease, thickening of the aorta from 5-HT2B receptor overload. So that is a concern, and that is, potentially lethal or, significant morbidity at the very least problem. And what does this mean? Does this mean we should limit it? Does it mean we should be testing people with cardiac echoes every year or two if they're microdosing? Or maybe we step away. I think we now have 4 or 5 studies on microdosing, LSD, psilocybin, and I think even one on MDMA, a naturalistic study, showing very little benefit from it. There is a sort of a shared placebo benefit of expectation that sort of everybody sees. But are they really doing something different than that? And if they're not, then maybe we shouldn't be using them in this way. But that's a concern I have. And as you say, I'm one of the few people that speaks out against microdosing because it's not just a minimized risk of psychedelics. I think, on the other hand, it's a maximized risk of psychedelics because of frequent dosing.
I'm sure, particularly with MDMA, I mean, that's definitely not a chemical that you want in your body a lot.
Yeah, but there are plenty of people around the globe who do MDMA even once a week.
Wow.
Yeah. Rave culture.
Oh, man. Club kids, how do they do it?
They're young. That's how
they're young. Yeah, that's true. Well, that was really a wonderful note to end this episode and this conversation on. And Scott, thank you so much for taking the time to chat with me today. I hope in the future, as things change, you'll be willing to come back and tell us what is new and any other skeptical concerns that you have that emerge as things, become on board and legalized. But this has been really wonderful. And thank you so much for chatting with me.
My pleasure, Anne. I had fun wading through skepticism with you.
Great. Well, bye, everyone. Thanks so much for listening.
Bye.